Good morning, everybody. Let's continue to talk about infective endocarditis. I remind you that you are looking, this is Healthcare and Education channel, and I am Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia. And today we continue to talk about infective endocarditis. So actually this is the second part, and we end on the treatment, and so we start with the treatment. Treatment of infective endocarditis, intravenous antibiotics based on the organisms and its susceptibility, sometimes valve debridement, repair or replacement, it depends. Dental evaluation and treatment to minimize oral sources of bacteremia, removal of potential source of bacteremia, for example, internal catheters devices. Treatment consists of prolonged course of antimicrobial therapy. Surgery may be needed for mechanical complication or resistant organisms. Typically, antimicrobials are given intravenous because they must be given from 2 to 8 weeks. Home intravenous therapy is often used. Any apparent source of bacteremia must be managed. Necrotic tissue debrided, abscess drained, of course, and foreign material and infected devices removed. People with infective endocarditis should be evaluated by a dentist and treated for oral diseases that could cause bacteremia and subsequent endocarditis. Existing intravenous catheters, particularly central-venous ones, should be changed. If endocarditis persists in a patient with a newly inserted central venous catheter, that catheter should also be removed. Organisms within biofilms adherent to catheter and other devices may not respond to antimicrobial therapy, leading to treatment failure or relapse. If continuous infusions are used instead of intermittent boluses, infusions should not be interrupted for long periods. Drugs and dosage depend on the microorganisms and its antimicrobial susceptibility for typical regimens. Although most patients are stable enough to wait for culture results, empiric antibiotic therapy before organism identification may be necessary in seriously ill patients. Antibiotics should not be given until adequate blood cultures, 2 to 3 samples from different sites over 1 hour, have been obtained. Antibiotics should be broad spectrum to cover all likely organisms, typically including sensitive and resistant Staphylococci, Streptococci, and Enterococci. Empiric antibiotic regimens should reflect local patterns of infection and antibiotic resistance. However, typical examples of broad-spectrum antibiotic coverage may include native valves, so vancomycin, intravenous 8 to 12 hours, prosthetic valve, vancomycin 15 to 20 kilogram, of course, intravenous, every 8 to 12 hours. In native valves, this is every 8 to 12 hours. As soon as possible, the empiric drug regimen should be adjusted based on the culture results. Intravenous drugs frequently do not adhere to treatment. Intravenous drugs abusers, druggers, frequently don't adhere to the treatment, even no druggers. Abuse intravenous access lines, we talk about druggers, and tend to leave the hospital too soon. For such patients, short course intravenous or less preferably oral therapy may be used. For right-sided endocarditis caused by methicillin sensitive Streptococcus aureus, nafcillin 2 gram intravenous every 4 hours plus gentamicin, 1 kilogram intravenous every 8 hours, 2 weeks is effective. And is a 4-week oral regimen of ciprofloxacin, 750 milligram twice a day, plus plus rifampicin, 300 milligram twice a day. Left-sided endocarditis doesn't respond. 2 weeks courses. For left-sided endocarditis, current guidelines recommended 6 weeks of parenteral antibiotic therapy. However, a recent multi-center randomized non-blinded study of uncomplicated left-sided endocarditis found that switching to oral antibiotics after a minimum of 10 days of parenteral therapy to be non-inferior to continued parenteral therapy. In addition, length of hospital stay was shortened to the patients switched to oral therapy. Obviously, this approach has the potential to reduce the psychological stress and some of the risk inherent to prolonged inpatient parenteral therapy. About surgery, so cardiac valve surgery, of course. Surgery, debridement, cleaning, so. Valve repair or valve replacement is sometimes required for treatment of infectious endocarditis. Surgery is typically indicated in patients with heart failure, particularly those with prosthetic, aortic, or mitral native valve endocarditis, and those with pulmonary edema or cardiogenic shock. Patients with uncontrolled infection, those with persistent infection with fungal or resistant organisms, recurrent prosthetic valve endocarditis, or endocarditis complicated by heart block, abscess, aneurysm, fistula, or enlarging vegetation. Patients at risk for embolism, particularly those with prosthetic, aortic, or mitral native valve endocarditis and large vegetations, defined, for example, in United States as more than 10 millimeters, of those with recurrent emboli. Timing of surgery requires experienced clinical judgment. If heart failure caused by correctable lesion is worsening, particularly when the organism is Streptococcus aureus, a gram-negative bacillus, or a fungus, surgery may be required after only 24 to 72 hours of antimicrobial therapy. In patients with prosthetic valves, surgery may be required when transesophageal echocardiography shows valve dehiscence on a paravalvular abscesses, valve dysfunction precipitates heart failure, recurrent emboli are detected. Infection is caused by antimicrobial resistant organisms. Right-sided endocarditis is usually managed medically. If surgery is necessary due to heart failure or lack of therapeutic response, then valve repair is preferred or replacement to avoid future prosthetic valve infection due to any continued intravenous drug use. Surgery is usually delayed for a month after intracranial hemorrhage or major ischemic stroke. Response to treatment. After starting therapy, patients with penicillin susceptible streptococcal endocarditis usually feel better and fever is reduced within 3 to 7 days. Fever may continue for reasons other than persistent infection, for example, drug allergy, phlebitis, infarction due to emboli. Patients with staphylococcal endocarditis tend to respond more slowly. Diminution of vegetation size can be followed by serial echocardiography. Echocardiography should be done at the completion of therapy to establish a new baseline for valvular appearance, including sterile vegetations and insufficiency. Relapse usually occurs within 4 weeks. Relapse. Antibiotic retreatment may be effective, but surgery may also be required. In patients without prosthetic valves, recrudescence of endocarditis after 6 weeks usually results from a new infection rather than a relapse. Even after successful antimicrobial therapy, sterile emboli and valve rupture may occur up to 1 year later. Risk of recurrence is significant, so ongoing lifelong dental and cutaneous hygiene is advised. Patients who require antibiotic therapy for any reason should have at least 3 sets of blood cultures drawn before antibiotics are started. About prevention. Prevention, dental examination and therapy before surgery to repair heart valves or congenital heart lesions is recommended. Measures to reduce healthcare-acquired bacteremia aim to curb the rising incidence of iatrogenic bacteremia and subsequent endocarditis. Dental and cutaneous hygiene is recommended for the general population, but particularly for patients at an intermediate risk, those with native valve disease and high risk. About high risk, the American Heart Association recommended antimicrobial prophylaxis. Prophylaxis for patients at high risk of an adverse outcome from infective endocarditis. Such patients include those with prosthetic heart valves, including transcatheter implanted prosthesis, prosthetic material used for heart valve repair, for example, annuloplasty rings, cords, previous infective endocarditis, a certain congenital heart disease, unrepaired cyanotic chronic heart disease, cyanotic including palliative shunts and conduits, completely repaired congenital heart disease during the first 6 months after surgery if prosthetic material or devices was used, repaired certain congenital heart disease that has residual defects at or adjacent to the site of repair. So heart transplant recipients with valvulopathy. About procedures. Most procedures for which prophylaxis is required for high-risk patients are oral dental procedures that manipulate the gingiva or the periphery or the preapical region of teeth or perforate the oral mucosa. Other procedures include those respiratory tract procedures in which mucosa is incised, vaginal delivery in some high-risk patients, patients with prosthetic cardiac valve or prosthetic material used for cardiac valve repair, and for patients with unrepaired and palliative cyanotic congenital heart disease, and gastrointestinal, genitourinary or musculoskeletal procedures that involve an area an established infection. Guidelines for the endocarditis prophylaxis vary geographically. So, prophylactic antibiotic regimens. For most patients and procedures, a single dose shortly before the procedure is effective. For oral, dental, and respiratory procedures, a drug effective against virulence group, streptococci, is used. For vaginal delivery, give ampicillin 2 gram intravenous or intramuscular plus gentamicin 1.5 milligram kilogram, intravenous administered within 30 minutes before delivery, followed by ampicillin or amoxicillin 6 hours later. For gastrointestinal, genitourinary and musculoskeletal procedures on areas involving infective tissue, antibiotics should be selected based on the known organism and its sensitivities. If infection is present but the infecting organism hasn't been identified, antibiotics for gastrointestinal and genitourinary prophylaxis should be effective against enterococci, for example, amoxicillin or ampicillin, or vancomycin for patients who are allergic to penicillin. Antibiotics for skin and musculoskeletal prophylaxis should be effective against staphylococci and beta hemolytic streptococci, for example, cephalosporin or vancomycin or clindamycin if infection with methicillin-resistant staphylococci is possible. About key points. Because the normal heart is relatively resistant to infection, endocarditis occurs mainly when there is a predisposing abnormality of the endocardium. Predisposing cardiac abnormalities include congenital heart disease, defects, rheumatic valvular disease, bicuspid or calcific aortic valves, mitral valve prolapse, hypertrophic cardiomyopathy, prior endocarditis, and intracardiac devices. Local cardiac consequences include myocardial abscess, conduction system abnormalities, and sudden severe valvular regurgitation. Systemic consequences include immune phenomena, for example, glomerulonephritis and septic emboli, which may affect any organ, but particularly the lungs, which right-sided endocarditis, kidneys, spleen, central nervous system, skin, and retina, with left-sided endocarditis. Do blood cultures and diagnose using Duke or European Society of Cardiology clinical criteria. Treat with a prolonged course of antimicrobial therapy. Surgery may be needed for mechanical complications or resistant organisms. Give antimicrobial prophylaxis for patients at high risk of an adverse outcome from infective endocarditis, including those with prosthetic heart valves or heart valve repair, previous infective endocarditis, certain congenital heart disease, or who are heart transplant recipients with valvuloplasty, with recipients with valvulopathy, or who are heart transplant recipients with valvulopathy. And of course, some words about non-infective endocarditis or non-bacterial thrombotic endocarditis. So, non-infective endocarditis refers to formation of sterile platelet and fibrin thrombi on cardiac valves and adjacent endocardium in response to trauma, circulating immune complexes, vasculitis, or an hypercoagulable state. So vasculitis or a hypercoagulable state. Symptoms are those of systemic arterial embolism. Diagnosis is by echocardiography and negative blood cultures. Negative. Yes, treatment consists of anticoagulants. Endocarditis usually refers to infection of the endocardium, as we talked above, infective endocarditis. The term can also include non-infective endocarditis, in which sterile platelet and fibrin thrombi form on cardiac valves and adjacent endocardium. Non-infective endocarditis sometimes leads to infective endocarditis. Both can result in embolization and impaired cardiac function. The diagnosis of non-infective endocarditis is usually based on a constellation of clinical findings rather than a single definitive test result. So, what is etiology of non-infective endocarditis? Vegetations are not caused by infection. They may be clinically undetectable or become a nidus for infection, leading to infective endocarditis, produce emboli, or cause valvular dysfunction. Catheter passed through the right side of the heart may injure the tricuspid and pulmonic valves, resulting in platelet and fibrin attachment at the site of injury. In disorders such as systemic lupus erythematosus, circulating immune complexes may result in friable platelet and fibrin vegetations along the valve leaflets closures, Liebman Sachs lesions. These lesions do not usually cause significant valvular obstruction or regurgitation. Antiphospholipid antibody syndrome, lupus anticoagulans, recurrent venous thrombosis, stroke, spontaneous abortions, livedo reticularis, also can lead to sterile endocardial vegetations and systemic emboli. Rarely, granulomatosis with polyangiitis leads to non-infective endocarditis. So, Marantic endocarditis. In patients with chronic wasting diseases, disseminated intravascular coagulation, mucin-producing metastatic carcinomas, for example, of lung, stomach, or pancreas, or chronic infections, for example, tuberculosis, pneumonia, osteomyelitis. Large thrombotic vegetations may form on valves and produce significant emboli to brain, kidneys, spleen, mesentery, extremities, and coronary arteries. These vegetations tend to form on congenitally abnormal cardiac valves or those damaged by rheumatic fever. About symptoms. Symptomatic. Symptoms and signs of non-infective endocarditis. Vegetations themselves rarely cause symptoms unless their size and location cause valvular dysfunction, sometimes causing dyspnea and or palpitations. Sometimes result from embolization and depend on the organ affected, for example, brain, kidneys, spleen. Fever and heart murmur are sometimes present. So about diagnosis of non-infective endocarditis, of course, blood cultures and echocardiography. Non-infective endocarditis should be suspected when chronically ill patients develop symptoms suggesting arterial embolism. Serial blood cultures and echocardiography should be done. Negative blood cultures and the presence of valvular vegetations but not atrial myxoma suggest this diagnosis. Examination of embolic fragments after embolectomy can help make the diagnosis. Differentiation from culture-negative infective endocarditis may be difficult, but it's important. An anticoagulant is often needed in non-infective endocarditis, but it's contraindicated in infective endocarditis. Assays for antinuclear antibodies and antiphospholipid syndrome should be done. Prognosis is generally poor, more because of the seriousness of predisposing disorders that can cardiac lesion. What about treatment of non-infective endocarditis? Anticoagulation. Of course, treatment consists of anticoagulation with heparin, either intravenous or intravenous unfractionated or subcutaneous low molecular weight. New oral anticoagulants and warfarin are not regarded as effective, although no comparative test trials have been undertaken in this rare condition. Predisposing disorders should be treated whenever it's possible. About key points of non-infective endocarditis. Non-infective endocarditis is much less common than infective endocarditis. Sterile vegetations form on heart valves in response to factors such as trauma, circulating immune complexes, vasculitis, or hypercoagulable state. The sterile vegetations can embolize or become infective, but rarely impair valvular or cardiac function. Evaluation is with echocardiography and the exclusion of infective endocarditis using blood cultures. Prognosis depends mainly on the underlying cause, which is often a serious illness. Treatment is usually with anticoagulation. So that's all. concerning infective and non-infective endocarditis. Thanks for your attention. Please don't forget to make your donations to our channel, because without your donations we can't exist. How to make these donations you can find in description of this video in YouTube. And of course, before you making your donations, please put on your ring. It's on the ring to be in touch with all news of our channel. Don't forget also subscribe and follow our channel, Healthcare and Education. So see you in the next lectures. God bless you. Bye.